while I'm doing the introduction, he's going to get the slides up for our next speaker. Dr. Beissner is a neuroscientist who is the endowed professor for somatosensory and autonomic therapy research at the Hanover Medical School in Germany. His PhD work used functional MRI to study the autonomic nervous system, and he completed postgraduate studies at the University of Porto, the University of Jena, and also at Harvard University with a Society of Acupuncture research colleague of mine, Dr. Vitaly Napadow. So Dr. Florian Beissner's presentation is called A TCM-based Psychotherapy with Acupuncture for Endometriosis.
Thank you. Thank you very much for the nice introduction, and thanks for having me here. It's been a great pleasure so far. And in the next, I think, 40 minutes, I'm going to show you some results that were gathered in a larger clinical trial that used acupuncture in combination with psychotherapy, and we used imaging and different other outcomes. And I'm going to show. Let's just get started. You'll see. Just gonna. So I just hope this will work, because we found out that there's not a perfect program installed here. Okay, so endometriosis is right. It's a continuation of the talk we had before, so you just move a bit more up and there you have endometriosis. So endometriosis is a puzzle, because endometriosis is a very common disease, and it's characterized by endometrium that grows outside of the uterus. That is clear, but the interesting thing is that some women develop pain from it and others don't. And this is something that we can say is completely not understood today. Yeah? It affects 6 to 10% of women in the reproductive age, so it's a very common disorder. And the most common symptoms are dysmenorrhea, up to chronic pelvic pain, and also infertility. So, the first-line treatments of endometriosis include standard analgesics, surgical removal of the endometrial tissue, up to hysterectomy, so it can be really intense. And of course, hormonal therapy to completely stop the monthly cycle or suppress the bleeding, which causes the pain. However, pain symptoms still persist in 30 to 60% of women despite seemingly adequate treatment, and that's quite a high number. So something is probably wrong here with the understanding of the underlying mechanism or with the treatment. So interestingly, there is a growing evidence now that psychological factors and alterations of the central nervous system are associated or play an important role in endometriosis-associated pain. So I told you not every woman who has these lesions develops pain. So actually it's quite a common incidental finding in surgery that women are diagnosed with endometriosis, but they said, oh, I've never had anything. I didn't know. Yeah. So also it has been shown that the extent of the lesions is very weakly correlated with the extent of the pain. Yeah. So several studies have shown that anxiety, depression, catastrophizing, and most importantly, previous traumatic experiences have a profound influence on pain severity and also on pain-related disability. And there is just 3 studies here that looked into this in detail, so if you want to look that up. So sometime in 2010, I was contacted by this lady here, Annemarie Schweitzer-Arau. She said she was interested in my work, and she developed this therapy. And usually I'm really critical when people that develop their own therapy approach me. It's kind of, of course, why don't you just show that my therapy is working better or how it's working? But in this case, it was different because they had already published a first retrospective trial that showed that what she was doing was apparently somewhat effective in reducing pain in these women with endometriosis. So, and she was collaborating with a colleague of mine, Karin Meissner. She's also quite a famous placebo researcher from Munich. And so I said, yeah, okay, I'm gonna give it a shot, and let's think about, can we do a trial about this. So first of all, I went there and I went to see what she was doing. So she's really combining elements from hypnotherapy, mindfulness-based psychotherapy, and sort of a bit of cognitive behavioral therapy with a Chinese medical diagnosis. And then she uses acupuncture, moxibustion, and other means to stimulate the points. And what she also does is she uses bodily symptoms as a way to induce trance, and then uses that to get back to memories that are associated with this bodily symptom. It's quite unique. I've never seen something like this before. So here are some guidelines that this therapy, this SART applies. So it encourages patients to release or express their emotions. So when there is sadness, they are encouraged to cry. When there is shock, they're encouraged to shake. And when there's suppressed anger, they move their extremities. So this is apparently an expression that helps getting rid of these suppressed emotions. It is there's a goal to harmonize ambivalences. There's a very interesting test. So she often puts or asks patients to put the father in the left hand, the mother in the right hand, and then she uses the bodily feelings to go on with the psychological process. It's kind of unique. So she calls it creative solution finding. So this is all translated from the German. So please be. I'm not a native speaker here, so it's. I hope this is all right. So, yeah, regulating temperature is another thing. So you can use moxibustion, but also emotional warmth and closeness, and also give some people experiencing this new experience of care for the first time. Yeah? There's many severe cases, of course. And then cool to bring down anger and outrage. You see the other points. You see that most of that is really inspired from general treatment guidelines of Chinese medicine. So she somewhat applies this on the psychological level. And a typical SART session will look something like this. So it takes 30 to 60 minutes, and it starts with a standard taking of the TCM diagnosis. And then there's a sort of introspective orientation. So people are asked to focus on their body, and she will ask them, do you have any pain right now? So in the moment. And then they will report pain, and then she'll use that. Usually it's pressure, tension, or pain. We call this a somatic marker, and that's used to search for memories that are associated with that. And that sometimes is enough to get people into this trance state where they then say, or she'll ask something like, when have you experienced this feeling before? And people will ask something like, I know I was really small, really young, and how did it look? Yeah, there are people in the room, and then this whole history, so this whole stories kind of emerge. And this also often goes along with strong emotional reactions, and people are encouraged to express these reactions. And then the memories, that's also very unique, are treated as if they are present experiences. So it's all real what's happening, but it's from the perspective of an adult now. Usually many of these things have happened when people were younger. And for example, if somebody wants to, she asked them what people want to do. If somebody wants to hide, then they can hide. They will stand up and hide somewhere in the practice. It's very, very uncommon. I've seen very strange things there, but it works for some reason. So she uses the figurative language of the patients to guide her TCM diagnosis, because patients will often say things that they will refer to certain animals that are quite uncommon. So, like, who would refer to a scorpion? How does the pain feel like? It feels like a scorpion. We have no scorpions in Germany. It's just, here's the same thing, right? How do people? Why these associations? But she uses that to come to the TCM diagnosis. And then acupoints are chosen according to TCM syndromes, and then there are loops. So then she uses acupuncture and or cupping or whatever suits the patient best, and this may resolve the problem, or it may uncover a deeper emotional conflict, and then this whole thing is started again. Yeah? So that's just very roughly how it works. If you ask the patients, and we did this in the trial. We had some qualitative part. We asked them, what do you think is going on here? What do you think is important of this therapy? And how would you describe it? And they say it's a feelings acupuncture talk. It's dissolving pain, anger, or depression that resides in a body region. Yeah? So this localization of symptoms in the body, I find this quite interesting. So it's concentrating on a region, dissolving it with the images, so that refers to the images that come to the mind, then insertion of some needles, and afterwards I feel well, supple, and relaxed. Somebody else says a combination of therapeutic interview, bodily sensations, and stimulation. During acupuncture, something changes in the subconscious. So also there, the direct connection to psyche. And acupuncture needles support the image-based work on experiences with bodily sensations and dissolve pain and emotions. So the patients really do perceive it as it is intended, although there's not much explanation going on. It's really right working with the sensations and whatever the patients say. So how do you study such a therapy? It's actually quite difficult because it's highly individualized, it's multimodal, it's a mind-body therapy. So we took this mixed methods approach, but I'm going to focus today on quantitative methods. So we wanted to know something about the mechanism, so we used brain imaging, functional magnetic resonance imaging, and of course we collected clinical outcomes. So we designed it as a pragmatic trial simply because it's impossible to construct any placebo intervention that will be comparable. Yeah? So it's talking, it's psychotherapy, it's acupuncture, it's impossible. So a pragmatic trial. We made no attempts at standardizing the treatment, except we asked her to exclude herbs, because we wanted to see, it's psychotherapy, it's stimulation of acupuncture points, not herbs on top of it, because she would use herbs, and we could convince her just in the first 3 months, which was our randomization period, to not prescribe any herbs. So we had practitioner-blind group allocation, and that's very important to avoid bias and to increase the internal validity. So we had the practitioner, or the gynecologist would see the patient and would then call the lady, Professor Beissner, who was responsible for randomization, and she would say this lady goes into group A or B. And that's, I think, the best way to do it, because then there is no bias from the gynecologist. People that suffer more will get the treatment earlier and so on. Okay, the randomization period was 3 months, and we had a long-term follow-up after 2 years to see if this effect would last. So here's the study team. It's very important to have a good team because we had almost no funding. We had 5,000 euros. That was to fund the research assistant to help with the MR imaging, 5,000 euros. And that came from a private trust that was funding me at that time, still is. And so it was very important because we all did this just because we were interested and we wanted to really know what's going on. So Annemarie Schweitzer-Auer, she did all the therapy sessions, I don't know, hundreds. And Karin Meissner was instrumental to develop the randomization protocol, clinical data collection, and so on. Christine Preibisch did most of the MR imaging. Roxana Popovici did the gynecological exams. I did the data analysis and planned the whole study, wrote the paper. Okay, so 5 years later, we have 2 nice publications that were published in quite high-ranking journals. So that's the good news. In the end, it all worked out. It took 5 years. I had 3 different positions in that time. I took the data to each new position, working on it in the States. I worked on it back in Germany. I worked on it simply because it was so much data. You can't believe it. So here's the design. So we had 2 groups. And one would get the treatment immediately, and the other one would be a waiting list control and would be treated after the randomization period. So we wanted to see if the patients that were treated got better than the patients that were not treated, but also if the untreated patients would show the same effect later, as you would expect. So we had 3 exams where people would come in and would be seen by a gynecologist also, and on each exam there would be an MRI. And then after the third exam, after 6 months, that was the end of the study, but we followed people up, and if they needed more treatment, they would be treated, but 63% had completed therapy when we looked again at the patients at follow-up 2 years later. Okay, the primary outcomes were changes in brain structure and function, and most importantly in functional connectivity. That is how brain regions talk to each other. Yeah? So how, I'm going to tell you that in some detail later, but that was the most important primary outcome. So the study was also powered for this primary outcome and not for the clinical outcomes. It's important. And we were focusing on brain areas that are processing pain and emotions, because those are the things that are central to the therapy. Secondary outcomes were reduction of pain by 50% or more. That is quite a high threshold. You would not expect this in most pharmaceutical trials that test analgetics. 50% pain reduction is a lot. So we explicitly formulated this dichotomous outcome, so responder, no responder, and we published this in clinical trials in the database so that we could later see if we achieve the goal or not. So then secondary outcomes, changes in pain and quality of life scores, and then normalization of menstruation, pelvic pain, dyspareunia, and defecation pain. That's dyspareunia is pain during sexual intercourse. Okay, there's many more problems, because when you do brain imaging, many things affect brain function and structure, and one of them is hormones. So you're measuring women in their menstrual cycle. Of course, the hormones change a lot. So we needed to find a point where the hormones were sort of stable, and that's this phase here. So during menstruation, so after the second day of menstruation. So that also means that if you have a couple of, I think we had 150 exams or so fMRI exams, they all need to come in a very short, very narrow time window. So it's a hell of an effort to organize this. So the imaging detail I will spare you. Data analysis also I'm going to talk about later. So, but the important point is we had to take all the exams between the second and the sixth day of the menstruation to keep to know that the hormones were at a steady level. Because maybe if that was not clear, so you can see if you just look at two different points in the circle, in the cycle in women, you will see connectivity changes, for example, in fear-related areas. That has been known. So women during menstruation will show more activity in their amygdala, for example, which is a fear-relevant area. So of course these hormones do cause measurable changes in the brain, which you could judge from changes in behavior in at least some women at that time. Yeah. So here's our study sample. We recruited 67 patients, and I just focus here on the pain outcomes because you can see that these patients were really heavily affected. So they had a maximum pain on average of 7.5 or to 7.7 points. That's on a 10-point scale in the two groups. Here. Yeah, the average, so that's the maximum pain. So during menstruation, the average pain was 4.9 or 4.1. So it's very much pain. They have all been, they had all had histological confirmation of endometriosis. So we had very strong inclusion criteria, and they have suffered for pain a long time, usually more than 5 years. So here's the flow chart. So we assessed 139 patients, included or randomized 67 of them, equally to both groups, so almost equally. And we lost very few people in the randomization phase, which is good. And then at 6 months, we still had 28 groups in the intervention group and 21 in the delayed intervention group. And what this doesn't show is that follow-up, we still were able to reach, I think, 60% of the patients, which is very good. So now, this is important, the role of trauma. So I was talking about this quite vaguely, but here is data from these patients. And here's the cases. This is the group 1, group 2, it doesn't really matter, so it was equally distributed. And here are the trauma, the causes of trauma or say adverse life events that were uncovered in the therapeutic process of being central to the disease. So those were the life events that therapy, the psychotherapy would focus on. And there is I don't know if you can read it, it's hard for me to read it here, but there are many cases of alcohol abuse in the family, abusive behavior, even sexual abuse. That's quite common. It's shockingly common actually in these patients. This is not to say that endometriosis patients have a history of trauma. We're absolutely not saying that, because that would be, of course, really bad. Endometriosis is an organic problem. We're just saying that those women that suffer a lot of pain, they may suffer more often than other women from these traumatic, or may have had traumatic experiences before. And we had in 18 of these 67 patients, I don't know why the numbers don't add up here, but so in 18 patients, we had no life events, so it's not that she finds something in everybody, but the majority of 45 patients had at least one or more adverse life experiences, and those were mostly death of a close relative or friend, but also sexual abuse, domestic violence, and abortion, even experiencing homicide, so really horrible things. Okay, so after 3 and 6 months, we assessed the clinical outcomes, and here is what we found. So in light blue, you see the intervention group, and in there's 2 dark blues. So the middle blue is the control group, and so you can see that these graphs need to be explained. So here you have this white dot. That's the mean value, and here's the this is like a tiny box plot, and this shows you the distribution. Yeah. So you can see that some outliers here will still be on top. But for example, or here you can better see it. So you can see that on average, people get better, but there's still some people that don't get better that are still up here. So this is how this plot is going to be read. So we start here with fairly similar values, and then only the intervention group gets better by almost 2 points here, in average pain, and here in maximum pain it's even stronger, the reduction from 8 to about 4 after 3 months. And then once we start treating the control group, so they receive a delayed intervention, they also show the same behavior and get better here after 6 months and after 6 months here. And the dichotomous outcome was that, remember we said at least 50% pain reduction, and that was met in 57% of the treated patients after 3 months, and only 18% in the control group. So that would be a regression to the mean, probably. Maximum pain, 44% got at least 50% pain reduction compared to only 4% in the control group. After 6 months, when these people were treated too, we see the same effects. Those patients in the intervention group even get better, but the difference between the two is no longer significant. So needless to say that the effect sizes here are moderate to large. So we had effect sizes around 0.6 to 0.8 or higher. So it's really clinically highly significant, highly relevant what's going on here. So other outcomes, anxiety, depression, quality of life, you can see here we see improvements in all of them. So they get less depressed, their mental health is increasing, they have less anxiety. It's all significant and has high effect sizes. And this is after 2 years and the follow-up. So 2/3 were no longer treated at that time, and you can see that the effects are still stable. Yeah, they are still stable and still really strong. So here the effect size is 1, 0.69, 0.66, 0.96. So these are really superb effect sizes. And well, you can see anxiety, depression, functional well-being, maximum pelvic pain. This is all improved. And also we had a very nice outcome that we did not assess was successful pregnancies of people that were considered infertile before. So there were 15 women that had an unfulfilled wish for a child, and 9 of them had given birth at the follow-up. Responder rates also, so people were still, 60% of the subjects still had at least 50% pain reduction after 2 years, and 56% for maximum pain. And also this is something you will almost never see in a study. 35% of patients had 100% reduction of their pain. That means they were pain-free. This is something you will not achieve with surgery or medication. It's really unusual what's going on in this therapy. So the interim summary is that trauma and other psychological factors are central to the understanding of pain related to endometriosis. And a body-oriented psychotherapy aimed at resolving trauma combined with acupuncture point stimulation is an innovative and promising approach to the treatment of endometriosis-related pain. Clinical effects are generally high effect sizes, had generally high effect sizes and show long-term stability, and 1/3 of patients experience permanent and complete relief of their symptoms, that is pain. Yeah. Okay, so which brain structures might mediate these effects? And here's a hot candidate. You see a seahorse, and the Latin word is hippocampus, so it's this brain region was named after a seahorse because when you cut it out from a dead brain, then it assumes the same form. So the hippocampus is an interesting region because, first of all, it's really old. It has been there in the brain for a long time. And it has 2 parts. The anterior part is involved in emotional memory, stress responses, and autonomic functions, whereas the posterior part processes declarative memory, so things you need to, facts and knowledge, and also spatial memory. And we thought that since we are dealing with traumatic experiences and memories, and since they are related to emotions, the hippocampus would be a good region to start our analysis. So I think I have to tell a bit about functional magnetic resonance imaging because it is not an easy technique and it's not easily understood, and most of all, it generates images that people feel they can understand, but it's really suggestive. Yeah? It's also, I think people abuse the images also sometimes because, yeah. So the brain lights up. Yeah? Everybody has seen this. The brain lights up in this area. What does it mean? What does it mean? The brain lights up. Yeah? It doesn't make sense. The brain doesn't light up. There's no light in the brain. It's dark. If it's in the skull. So what I'm going to show you is what these images actually mean. So we have our neurons. They consume glucose and oxygen. So this somehow needs to be supplied to them, and of course it comes with the blood. And what happens if a certain area increases its activity is that you will also have an increase of blood flow to the area. And then you see that there's these little red dots and blue dots. They are oxygenated and deoxygenated hemoglobin. And so you see that when the vessel opens up, there is more oxygenated hemoglobin coming into the region. And interestingly, and you cannot see this on this slide because this is not moving, but hemoglobin has an interesting property. It changes its magnetic behavior when it binds oxygen. So that's very fortunate for us because then we don't need a contrast agent. We can just use the blood. Yeah, so we can measure these magnetic changes in an MRI using a high-resolution sequence, and we can see these tiny changes in magnetic behavior that are coming from the differences in perfusion. And so we have an indirect measure of brain activity. And what we usually do is we apply an external stimulus, so we switch on light and switch it off again, so we know when we can expect changes in certain brain areas. And then we look at the signal, these so-called bold signals, so the blood flow changes in certain areas, and we look for similar time courses. So when we switch on the light, we expect that the visual cortex, for example, will also increase its bold signal. Then we know, okay, this is related to the stimulus. And then we generate these images, and these images are basically statistical maps color-coded in a heat color code map, or the color bar is usually representing heat. So you go from red to yellow somehow. Somebody decided that this is a good color, so this is why the brain lights up or glows or whatever. Yeah. So, but what this shows is areas with high values, with high significance, high correlation coefficients. So where this time course is very close to this time course, they will get a high hot color. And there's also two very different kinds of images. Well, actually, the images look exactly the same. You cannot tell them apart, but they mean very different things. So this is what I just told you. So we have an external stimulus, and you're looking for changes in this bold signal, so the blood the perfusion signal, and it will generate images like this. So the question is, which brain regions are involved in the processing of an external stimulus or cognitive process? But you also have this, where you what we call connectivity. So you start somewhere in the brain, look at that signal, extract that signal, and then ask which other brain regions have a similar signal. Yeah? So whenever one brain region starts to fire, which other brain regions also start to fire? So we call this functional connectivity because we assume that these regions have something to do with each other. Okay, so here we're going to focus on connectivity. And sorry, this is really, I'm sorry, but I hope this still works for you. So the analysis that we did was, as I said, focus on the hippocampus. Here is the hippocampus. This is the cerebellum. It's not a medial section. It's slightly from the medial line. So here is an eye, yeah, and this is the sinuses, the maxillary sinuses. So here's the hippocampus, and I had shown in a previous paper that we are able to separate this anterior and posterior parts of the hippocampus using information from this functional connectivity. So we could simply ask which regions within the hippocampus are talking a lot to each other, but not so much to the other regions. So then you get this segmentation of the hippocampus, and we ask ourselves which of these brain regions are talking, or which other regions of the brain are these regions talking to? Because it's not, the memories are not in the hippocampus. It's just the hippocampus is essential for accessing these memories and forming these memories. Yeah, but they are somewhere in the brain. They're probably distributed. So just looking at the hippocampus is not enough. So we looked at this connectivity, and we correlated it with changes we saw during therapy. So the result was that in the sample we were studying, we could replicate this segmentation of the hippocampus quite nicely. So this is from the clinical trial. This is from my previous publication. So you see there is these different subregions: the anterior, anteromedial, and anterolateral hippocampus, and then the mid and posterior portions, and it's kind of symmetric also. So that's a good thing. Replication of earlier results. Well, now we can look at this. This is to show that each of these regions have a quite different connectivity profile. So those are the regions in the brain that this subregion is significantly connected to. Yeah. So you see differences, especially you see that only some of them are, for example, connected to the somatosensory cortex. Only these two basically, and this one a bit. Not all of them. So this is the differences, and they are of course functionally meaningful. And for our therapy, we looked at each of these subregions, and we looked for those regions that showed an interaction, so where the two groups would show a different development. And so here you can see that for the right anterolateral hippocampus at baseline, so the groups didn't start at the same value here, but the movement was completely opposite. So in the treatment group, the connectivity to the rest of the brain increased, whereas it went down in the control group. And then after the treatment, after the control group was treated, they kind of meet in the same value here. And we had exactly 3 regions that would show a similar effect. Yeah, so an effect where you would first see a difference, so an interaction here in this randomization phase, and then later they would become more similar. So then we went on to see, are any of these changes related to clinical changes we see in the patients? And interestingly, this was the case for only the anterolateral hippocampus, the right anterolateral hippocampus, so it's lateralized, and this showed at baseline a significant the correlation with the maximum pain and with anxiety. So those two. The others did not show any significant correlations, and so we didn't follow them up anymore. Okay. So finally, we found that the right anterolateral hippocampus has a network of other brain regions that it changes its connectivity with when these patients get better, and that is somatosensory areas. And that's really interesting. So somatosensory and interoceptive areas, so areas that are processing signals that come from your body. So it kind of makes sense. So the results are showing that the therapy is working on this connection between memory processing areas and areas that process input from sensory input from the body. And so this is, I'm going to skip this too. So this right anterolateral hippocampus is not an unknown. It's known to control the HPA axis activity. So as an interim summary, again, we have identified a potential neurobiological mechanism underlying this potent combination of psychotherapy and somatosensory stimulation. And clinical, the reduction in this connectivity in connectivity was associated with improvements in patients' anxiety. And there's one thing I want to briefly show you, because that's what I'm working on now, and what's really remarkable about this therapy, again, it's, I mean, do you know that? What's that? Any idea? That's needle sensations, yeah, with or without needle. Yeah, so in this case, it's sensations that are partly from acupuncture, but also from all other interventions. So it's really a mixed bag. But you see that these are sensations that people report during this therapy, and you see that it's mostly warmth and tingling and a light feeling. And what we did in a follow-up trial with a very similar group of patients that got the same therapy is we had them draw these sensations that they have during the therapy on such a tablet computer running a specially developed application to do that. It's very easy to draw. It's like pen on paper, but you can analyze it statistically. And then we get these very weird and widespread sensations that people have during the therapy. And when you ask them, how did it feel, they will tell you extreme things like, I felt like there was a cold wind blowing through the left side of my body. And then I knew something important happened. So this therapy elicits very strong sensation. Anne-Marie was not reporting this because it was normal for her, but it's very rare that I see this anywhere else. And then last slide, we asked them, these patients, what is their perceived significance of these sensations? What do these sensations mean to you? And then the majority of them thinks they are very important to what's going on in the therapy. So they are a bodily expression of emotional processes, say 62%. They are an important part of the therapy, 52%. They are an expression of my life energy. So there's this direct connection between sensations and energetic, concepts. They mean that I am being healed, 38%. And now also more esoteric concepts, the therapist is guiding her life energy into me. So that's not coming from the therapist. She would never say something. She's a medical doctor. She would never say something like this. But the patients come up with these explanations because they cannot explain these sensations in another way. And then only 9% say they are only sensations, or I don't know, just 7%. Okay, and this is my finally last slide. So just 6 different people here that drew their sensation, and then look at how this really looks like early versions of the meridian. So no zigzag here on the shoulder, but really this smooth form here, and also the meridian continues in a completely different fashion. So like in this guy here. So this is why I think that these sensations are really crucial to the development, or were really crucial to the development of meridian concepts, and I think they should be studied much more. Okay, thank you very much, and thank you for my
Well, great to hear those two very interesting presentations. Lee, why don't you come up here, and if anyone has questions, we'll circulate the microphones around, and you can ask either or, and if you're waiting for a question, if either of you have a question for each other, you're welcome to pose it.
So yeah, just
Any questions in the audience?
Thank you for two speakers. Lovely. I learned a lot from you. My question for Lee regarding for your clinical pilot trial for the vulvodynia. This is, as a practitioner, I know, we all know, this is a very challenging case for treatment. But my question for your the research design, I noticed that you have two groups. One is the traditional acupuncture plus lidocaine. Another one is the non-traditional acupuncture plus lidocaine. Do you have another group with lidocaine only?
I wish I could have afforded that. Because my original proposal was to look at just acupuncture compared to just lidocaine. Yeah. And when I took that to the IRB at my institution, they were like, no, how are you going to account for the time and attention that you're providing to the acupuncture patients or participants? And how are you going to account for that with your lidocaine patients? So, and they said, we're not going to approve this, even though I'd already gotten funding through the small organization that funded the study. So I had a very small budget, and I had to pay for the lidocaine, and as you saw, we lost 2 people because we were using commercial lidocaine, and so then I had to go and get satellite delay again. Compounded, thank you, compounded lidocaine, and that cost more, which took more out of the budget. And I really all I could afford was to pay for the lidocaine, my research assistant, and the other acupuncturist. So that's why we don't have that third arm. If I could do this again, of course, I would have loved to have had that. But I think the great thing about the pilot study is not necessarily are we showing that this is going to provide a great benefit to the patients, but did they accept the treatment? They totally accepted the treatment. The other thing is that I didn't present in the trial presentation just now is that 10 out of the 14 patients, you made me remember this, 10 out of the 14 patients had a 50% or greater reduction in pain at 12 weeks, and 9 out of them had retained it at 24 weeks. So we know that they're responding to the treatment. Which one, I don't know. My bias is that I want it to be the traditional Chinese medicine side, but it's confounded by using those the minimal needling group.
Anyway, thank you. Hopefully in the future I can see more the methodology design. That's going to be more interesting, more attractive, and more evidence. Thank you.
Hi. Great presentations from both of you. Thank you very much. Lee, I've got a question to you. Using 2% lidocaine, and it's 2%, which is a stronger dose than 1%. Can you possibly tell me how often are the patients or clients are asked to apply the cream? How often? What's the duration of the action of the local anesthetic? And the last is, what are the complications? Have you had any complications or side effects as a result of using local anesthetic on the vulvar area and also pelvic floor?
Those are all great questions about the lidocaine. Well, as you saw, we lost 2 people because of lidocaine sensitivity. We asked them to apply the lidocaine 4 times a day. It was a 5% cream, and that was the same concentration that was used in a randomized controlled trial looking at lidocaine and oral dicipramine. It was like one of those 4-armed, I forget the term right now, where the 4-armed, where they had a placebo with the real cream, placebo, real cream, real drug, and then, so what is that called? I don't know, I can't remember right now. So in that study, the real lidocaine was not superior to the placebo cream. So because of that, in that gold standard, I guess, trial, we decided to use that as the sort of baseline treatment because it is an anesthetic and it does provide some symptom relief, for at least for the moment. But the things that we got in our daily pain diaries is that they did get a little stinging with the application when they first started using it, but after a few days they were able to tolerate it and didn't notice it as much. So they kind of accommodated to it, I guess you could say. And what was your third question?
My last question was any side effects of the use of local anesthetic on the pelvic floor? which is the vulvar area, obviously, from vagina.
Side effects aside from the burning?
Side effects? Yeah, no, not necessarily. I was just saying, as a local anesthetic, you can cause, you can get symptoms such as stress incontinence, or even I have heard of hemorrhoids and piles as a result. So I've just heard about it, and I was wondering if you have experienced that.
No, I have not, and we asked them, the participants in the study, to report any new health issues that developed during the study. No one reported either of those.
Okay, thank you.
Yes.
Hi, thank you for the excellent presentations from both. I have a question for Professor Beissner. First is, when your fMRI scanning is done, was any acupuncture therapy
So when it was,
before the MRI scanning? Was patients given acupuncture?
yeah, so that's, sorry, I think I wasn't completely clear. This was a so-called, I'm not going to find it that quick. This was a so-called resting state study.
Yes.
So when you put people in the MRI, there is no stimulus at all. You just have them for 10 minutes.
That's right.
The exams were completely independent of the treatment sessions.
Yes.
Yeah, and there was no relationship. So there was nothing happening during the scanning or before the scanning. It's just really comparing this baseline measurement, so the resting state between different time points.
Okay.
So the brain at rest is really changing its connectivity here.
Okay, so it's unrelated to any treatment.
Yeah. Only that it's after 3 months after they received a couple of, a fixed number of treatments at least. So they had to receive at least 5 treatments in this treatment period, and So
the second one is for your analysis of sub-region of hippocampus.
yeah.
For your comparison is compared with all brain.
It's not a comparison. So what's the question?
The question is, your comparison is sub-regional
Yeah.
hippocampus analyze the activities of the blood flow
Yes.
by MFRI. As for your slides, it compare all brain connectivity.
Yeah. Okay. So we start. Do I find this? Yeah. Here.
Yeah, that's right.
So we start with. I think I got the question. Thank you. It's a good one too. So we start with the segmentation of the hippocampus. That's the first step. Yeah?
Yes.
So we just look in the hippocampus and we ask which regions are more talking to each other than to other regions.
Right.
But then we test the connectivity of each of these regions with the rest of the brain, because as I said, we don't expect the emotions and emotional processes to take part only in the hippocampus, but we know that the hippocampus is crucial. So we look at connectivity from each of these subregions to the rest of the brain. So we ask, are there any regions in the rest of the brain that this hippocampal subregion talks to more or less after the therapy? And then we find the somatosensory cortex talks less to the anterolateral hippocampus after therapy.
Do you compare the data from two sides of the hippocampus?
Left and right, it was only on the right side.
Only right side.
It was only on the right side. And the interesting thing is that there has been, I skipped this one, but there was a study in PNAS where they showed that in, I think, macaque monkeys, there is one subregion of the hippocampus, and that's on the right side only, and it's only the anterolateral, so the one that we found the changes in, that is triggering the activity of the HPA axis, so the release of cortisol from the hypothalamus, so the release of cortisol triggered by the hypothalamus, the pituitary adrenal axis, HPA axis. So this is controlled in part by that particular region of the hippocampus only on the right side of the brain for some reasons that we don't know. Yeah.
The last, why don't you compare right to left?
No, we did explicitly compare right to left. It was just not something we reported as primary. So we checked if there were laterality differences, and there were, so this was only significant on the right side, but also the left-right difference was significant. So we did test that, and it was only the right side.
Thank you.
Yeah. You're welcome.
Hi, this is Lee. A question to you. I noticed at the end of your talk, you mentioned the placebo, if I remember rightly, unless I was dreaming, and the lidocaine was no different from placebo, but there was no placebo arm, and I'm trying to work out how did you work that out? What was your thinking behind that?
Very good question. So in level 1 evidence where lidocaine was compared to a placebo cream, there was no difference between them in that randomized control trial. And so that's the reason why we use lidocaine as sort of like the equalizer between the two groups. So if this is a, quote, placebo, then maybe the benefit of this treatment could be attributed to acupuncture alone. So the effect size is considered nil, according to my colleagues, even though it looked like in the text of the paper that it might have been actually 16 to 18% reduction in pain with lidocaine. So I don't know how much is actually attributed to just acupuncture in this study, but I think there's a signal here that there was a benefit for sure.
Okay, thank you.
Florian, so I'm a I'm a believer that the effects of acupuncture are more than just needling. We know that there's a lot of other things that are unique to acupuncture or East Asian medical therapy that go beyond just the needle intervention.
Absolutely.
Do you have any thoughts or insights based on working on this for 5 years about that?
About that. So the question is, what I think, which other factors contribute to the effect of acupuncture, to the efficacy of acupuncture effectiveness? Well, of course, there's many, and there have been very, very good studies that start from, everything that's done except for needling. Even taking the diagnosis is something that is very beneficial for most patients. Describing their symptoms in detail can be something that people are, they like to do, that they feel understood if somebody asks them in detail for their symptoms. And it ends somewhere in how empathic is your practitioner. Yeah? So how much can you relate on this level? So this has all been, I think there have been quite some high quality studies on that, although it's mostly qualitative studies. But they're supposed to be qualitative because otherwise you don't understand what's going on. Yeah? So you need to ask the patient, you need to take him serious and ask him what do you think, what is important right now. But then you can also, of course, try to measure the effect, the clinical effect of these different these effects. For example, I remember there was one. Maybe you can help me with this. There was one study from Ted Kapchuk where there were practitioners, and one of them was really empathic, and augmented. Yeah, so the augmented acupuncture versus some acupuncture without much looking at the patient, just putting the needles in. And of course, the augmented acupuncture is more. It works better. Yeah, so it's not a surprise. It's actually one of the big problems to really separate all these things from these complex interventions. Was it on your slide where you had the order of, looking into the whole therapy and then looking into the components of the therapy? That I think it was.
Hugh,
Oh, that was your slide. Yeah. So I kind of like that. So first you have to see if the whole thing is, meaningful, and then you can say, okay, now I try it without the herbs, and I try just the acupuncture and see if it's still working. It's a long process. Yeah. Okay.
Can I ask one to Lee? Lee, do you, did you find that women in this study talked about any of their traumatic experiences, or was that something you just allowed to happen if it did, or you tried to elicit, or Any observations in light of some of the comorbidities?
That's a really good question. The methods of the study did not really allow for a lot of qualitative interviewing outside of the initial interview of getting the TCM diagnosis. So if a person volunteered trauma on the first visit, then it would be annotated and recorded. And we did the chart reviews because nearly everyone came from the university health system. So I guess my answer is no, we didn't really look at that. I think that's the simplest answer. But the second piece, though, that I think is also important to kind of acknowledge is that how did the patients respond emotionally over time? And we assess that using the PROMIS scales like you did. I didn't report the data because it would have taken way too long and too much time. So it'll be in the paper on how, we use similar domains to you, like pain interference and pain severity, that sort of thing, anxiety, depression, global health, and vulvar discomfort. But the challenge that I found with the PROMIS scales is that they aren't always as translatable as some of the other well-known scales, like the Female Sexual Function Index, which kind of looks at lots of the aspects of functioning with female sexuality. It would be great to go back and kind of do a qualitative interview with the patients and kind of get their experience. I purposely tried to, because I was doing a lot of the treatment and doing it for free, I also had to be mindful about the time and trying to get people in. And so I just really, I didn't want to be flat, but I didn't want to just, I wanted it to kind of be about the treatment and not so much about me. And because I could do that in the other research because we had more providers. So I mean, I guess I'm not really answering your question well, but that's kind of what happened.
May I comment on that? I think it's generally very difficult to have a questionnaire that assesses trauma. Because that's why in this study we noticed that because we wanted to include it from the beginning because of course the therapy is aimed at releasing trauma. But you know, the questionnaires really often don't get to the point and frankly, many patients are not aware when they come to the treatment that trauma is the cause of their, or is one of the causes of their problem. And these things will often only come out, it's a hypnotherapeutic intervention, so they will come out in trance, they will come out spontaneously. And people will only in that process remember that something was going on. Those were often early childhood experiences. And if you give them a questionnaire that asks them, have you been sexually abused as a child? Then probably many of them would have said, no, of course, no. No, what a question, yeah, no. And so these questionnaires are, I think, yeah, it's a problematic, yeah, they're limited, yeah, what they can do, yeah.
One comment about both of them is that although it's nice to get a lot of money, it's amazing what can be done with just a small amount of money, so brilliant, both of you. And a couple of quick questions for Florian. One was, and the results are so stunning from this, is what impact, if any, they've had in Germany. And the second was, given the sort of singularity of the therapy, to what extent do you think it can be reproduced by other therapists in other settings?
That's very important. I'm going to start with the second question because we always urge Anna-Marie to spread her knowledge, and she's really okay. No, we don't need that. She's really open in sharing. So if you call her and said I want to learn from you, you can go there and learn it from her without you. She'll not charge you any money. You just have to wait a long time. Yeah. So it's not about that, but. Really teaching these techniques and getting it out is super important. So she's planning to do some sort of program where first in Germany where people can learn that. So it's going to be under the auspices of one of the large acupuncture associations. But yeah, it's very important that we do that. And from my personal experience, I don't think it's a complicated therapy. Because interestingly, while we were doing this trial, so Annemarie was super thankful that we pushed her so much into, you know, getting better in a shorter amount of time, leaving away the herbs, leaving away this, you know. And she said, I'm so thankful because I really started to focus only on what is necessary. And nowadays, if you ask her to describe her therapy, she can describe it much, you know, shorter, and she really gets more to the point easier, because she really left a lot of stuff away and noticed it still works. Effects are still strong. So she's now started to treat groups, because it's enough. You can have a group treatment, and some people just come once. Yeah? But you also have to be careful, and that's maybe the first part, because of course you don't want to get into this healer image. Yeah? And when we try to submit that data, those papers, I can tell you, we got more than one reviewer. This was not accepted easily. Yeah? We got more than one reviewer that said, but what can we learn from this? There was one lady in Germany with a special gift, healing pain. Yeah? And also, I remember one particular reviewer said, but how can we control, how do we know that the therapist wasn't overly motivated? Well, that's the worst thing that can happen in evidence-based medicine. Somebody who is overly motivated and really screws the whole results in one direction. It's an outlier. We don't want that. You want everybody to be not too motivated, and that's evidence-based. Yeah, then you don't have a large spread, and yeah, it's controllable. So here, there's a problem. But of course, they are also right. Yeah, because you say it needs to be replicated. So we are now trying, I'm always encouraging the head of our pain outpatient department in Hanover to go and learn this therapy there, so we can apply it in Hanover and make the next trial a two-center trial, yeah, multi-center trial. So we are actively working on her most of the time to make that happen. Okay,
Okay, thank you so much. Let's give them a hand.